Hello everyone and welcome to the July edition of ISGyP LiVE Journal Club. I'm your host and moderator, Karen Talia. I'm broadcasting live from Melbourne, Australia. Joining me from the ISGyP LiVE team is Dr. Natalie Benet in Cleveland in the United States, where it's currently very late in the evening. So thank you, Natalie, for being up and joining us. Some of you joining us today are ISGyP members, and for those who are not, we hope this session encourages you to join the society. Membership fees are discounted if you're practicing in a developing country, and membership is completely free for trainees. And remember, if you want to participate in these sessions, you don't need to be a member of ISGyP. Our topic for this month is ovary, germ cell tumours and gestational trophoblastic disease, and we have 2 trainees and an early career pathologist presenting today. So as you all know, Journal Club alternates between the USA and Australia month by month, with Dr. Natalie Benet and I alternating hosting these sessions. But today I'm excited to announce that there will be some new faces on Journal Club in the coming months. Soon I'll be joined by 2 new co-moderators for our Australian sessions. So I'd like to introduce Doctors Deborah Smith and Rowan Lowry, both from the Mater Hospital in Queensland, and I'm very excited to welcome them both on board for the Australian version of Journal Club. So here's the schedule for 2022. We're just past the halfway mark, and I'm pleased to say that all of my slots are full for the remainder of the year. So if you want to join the Australian sessions as a presenter, still send me an email, and I'm starting a list of names for 2023, and I'll be in touch early in the new year to organise things. In addition to Journal Club, trainees and junior pathologists can also participate in case-based sessions, and the interesting case presentation sessions are moderated by both Dr. Jennifer Bennett in the US and now also Dr. Rubina Wadi in South Africa. So Dr. Wadi has some slots available for September and November, and if you're interested, please get in touch and she will organise that for you. This event runs to a similar format as Journal Club, with 3 cases per session and mentorship in the lead up to the day. Okay, so here are the learning objectives for Journal Club. Our primary aim is to engage junior and trainee pathologists in critically evaluating the literature and honing their presentation skills in a mentored and supported environment. We will provide you with a journal article, and we'll also offer written feedback on your presentation, and we'll run an online practice session to help build confidence presenting using this format. We'll also give you a PowerPoint template to help you put your presentation together, and this is a summary of that template and the main steps that we follow when we're walking through and appraising an article. So to attend Journal Club as an audience member or any of the ISGyP Live educational events, remember just to go to isgyp.ca, register there. You'll be sent reminders ahead of the session and a video link afterwards to watch the recorded session if you missed it. And recordings of Journal Club are also uploaded to YouTube. So we haven't had any ISGyP Live programming during July, but there's some things coming up in August that I'll quickly let you know about. In early August, we have Dr. Diego Castrillon presenting a webinar titled Challenges in the Diagnosis of Endometrial Hyperplasia. That's on August 4 at 12 noon Eastern US time. On August the 11th, there's a slide seminar, A Practical Approach to Vulva by Dr. Jacqueline Watkins, also at 12 noon Eastern Standard Time. And the last one to announce is a podcast with Dr. Kelly Devereaux titled Advances in Routine Molecular Subtyping of Endometrial Carcinomas, and this goes live on the ISGyP SoundCloud page on August 24. Finally, before we get started, this is an interactive session, and if you would like to ask questions, please use the Q&A button and we will address these at the conclusion of the 3 presentations. Please also use the chat function for general comments. Say hello, let us know where in the world you are today. And also at the very end of this session, an evaluation form will pop up. Please take the time to fill that up so that we can fill that out so we can continue to improve these presentations. So here's our schedule for today. Our speakers are Dr. Angeline Hansa, who's presenting a paper on discordant P57 expression in hydatidiform mole. We've got Dr. Jayati Datta presenting a paper discussing unusual and diagnostically problematic morphologic features in Dysgerminoma of the ovary. And Dr. Luke Beaumont presenting a paper discussing the phenomenon of bizarre atypia in placental trophoblast. So here are our three speakers. I'm very pleased to announce or to introduce Dr. Angeline Hanser, who's a fourth-year trainee at St Vincent's Pathology in Melbourne, Australia. Dr. Jayati Datta, who's in India, works as an early career pathologist in Kolkata. And Dr. Luke Beaumont, who's a final year trainee in Melbourne, Australia at Dorevitch Pathology. Okay, that's me done. So Angeline, when you're ready, I'll ask you to share your screen. And
sure.
Good to go. Thank you.
All right, I hope you can see that. Thanks, Karen, for the introduction and the opportunity to present. So I will be presenting a case report of a rare complete mole with unusual P57 expression. The first author, Kathleen Murphy, is out of the US and has a particular interest in genotyping of molar pregnancies, with quite a few articles encompassing both usual and unusual cases. So complete mole is an important diagnostic entity for pathologists. It occurs in 1 in 1,000 pregnancies and is a pre-malignant condition. We use immunohistochemistry to assist with diagnosis. As in complete mole, P57 is negative in the villus mesenchyme and the cytotrophoblast layer. However, sometimes the classical features are not present, which leads to a diagnostic dilemma. So in this case, it has a confusing case where there are classical features of complete mole, but with discordant P57 expression. I'll just explain on the basis of complete mole a little bit more. So the classical features include the absence of embryonic development. They've got edematous villi, you've got cavitation in the chorionic villi, and trophoblast hyperplasia and/or atypia. So there's an increased risk of gestational trophoblastic disease in about 15% of the patients, and that can include choriocarcinoma, invasive mole, or persistent complete mole. Incomplete mole, generally P57 is negative in the cytotrophoblast and the villus mesenchyme, and I'll show that in the following slide. But we do know what to look for with the P57 immunohistochemistry, but it's also important to understand the basis of why it's used and the biology behind it. So P57 is a protein that's encoded by the gene CDKN1C, and that is a strongly imprinted gene on the maternal chromosome. And so therefore it is expressed on the maternal chromosome and P57 is positive, but it's not expressed on the paternal chromosome because of suppression with a methylated group, and therefore P57 is negative in those cells. So therefore, by using P57 immunohistochemistry, we can tell if the tissue has maternal genetic contribution if it is positive. So here's an example of a complete mole. The top two photos shows the characteristic findings of enlarged villi, central cavitation, and trophoblastic proliferation around the outside of the villi. The bottom two photos show immunohistochemistry staining with P57, which shows negative staining in the mesenchymal cells and also the cytotrophoblast cells. But then you've got the internal normal control, which are positive. In this case, it's intermediate trophoblastic cells, but you can also have maternal decidua as an internal positive control. In addition to P57 staining, we can use genotyping to better understand the genetic contributions that make up a molar pregnancy. So generally, short tandem repeat analysis is used to detect short repeats of DNA sequencing, which accounts for about 3% of the normal genome. So each individual has a different amount of repeats, and therefore analysis can suggest different genetic origins. There are some classically well understood examples of genetic contributions for complete mole. Most are androgenetic and diploid. And that means that it's got complete paternal origin with either one sperm or two sperms, and there's a loss of the maternal chromosome. There is also diploid biparental, where there are maternal and paternal genetics, but due to a mutation and a global imprinting defect, P57 is lost in these cases. Another rare subtype has a maternal chromosomal mutation causing complete mole, but it still does stain with P57 as fragments of the P57 gene are still present. In comparison, partial mole has 2 sperm and also maternal DNA, which leads to triploidy, or 3 sets of DNA, which also retains the P57 gene, and therefore it stains positive. Moving on to the case now. The aims of the case report is to discuss discordant P57 staining and the approach to diagnosis and understanding the biology behind the discordance. So we have a patient who's 28 years old, presenting with vaginal spotting and a little bit over 15 weeks gestation. She has an elevated beta-HCG, much higher than you would expect at this gestation. So she undergoes an ultrasound, which shows an empty gestational sac and suggestion of cystic spaces, but no fetus. Because of the high beta-HCG, the impression is partial mole, and so therefore the patient underwent dilation and curettage, and the specimen itself showed evidence of vesicles and confirmation that no fetus was present. So here are the findings. So first we have the ultrasound images showing an empty gestational sac within the uterus cavity. The histology here shows classical features for complete mole with edematous villi, prominent trophoblastic hyperplasia and atypia, and central cavitation. Additionally, we do have gestational membranes found, which is unusual. Subsequent P57 staining shows that the star shows internal normal control. We've got a negative cytotrophoblastic layer, but positive staining within the villus mesenchyme. So hence you've got the histological features of complete mole, but unusual P57 staining, which is not in keeping with the patterns we readily understand. So therefore, this case went on to have short-hand and repeat analysis to better understand the genetic origins. So this is my most complex slide, and I'll do my best to explain it. So if we start off with the FISH analysis, it shows 4 different probes for 4 different chromosomes, which are labeled with different fluorescent dyes, and it shows 2 cell signals for each of the colors, which suggests that it's diploid in origin, so 2 sets of DNA. And this was present in both the mesenchymal cells and the cytotrophoblast cells analyzed. The STR results are a little bit more complex. So we have a total of 16 markers that were analyzed with maternal decidua and 3 separate villus areas. And then along the horizontal axis, we have 5 of those markers. We have maternal decidua for the maternal alleles here. And then that is compared with the 3 different regions, with regions 1 and 2 having more cytotrophoblasts and region 3 having more villus mesenchyme. The 3 areas demonstrate the same alleles and peaks at each locus, but there are varying ratios or heights of the peaks, which suggests mixtures of cells with different genetic constitutions. So that suggests that it's from 2 sperm, therefore making it dispermic. But in some areas, such as marker THO1, in areas 1 and 2, we've only got 1 peak, but then that suggests androgenetic origin, so just paternal, sorry. And in area 3, we have 1 maternal peak, it marries up with the decidua, and 1 paternal peak, suggesting that there's some maternal DNA in that the villus mesenchyme here. Adding to the confusion, the middle marker here, we've got 3 alleles in each of the areas that suggest 3 sets of DNA. However, as you remember from the FISH analysis, it only showed diploidy in the cells. So one possible explanation for these findings, the fact that there's 2 alleles in the absence of triploidy on FISH, is chimerism, so the fusion of 2 distinct zygotes. So with the fusion, you have different expressions of the genes based on the fusion of the 2 sets of DNA. The variability of the allele ratios or the peaks could be explained by the different ratios of the cytotrophoblast to villus mesenchyme in the 3 different areas. And the immunohistochemistry results could be explained with the findings that P57 is negative in the cytotrophoblast that contribute to 2 paternal alleles. And in the P57 positive mesenchyme, that may be due to the maternal allele also being present alongside the paternal allele. Just to follow up the case, the patient underwent serial beta HCG measurements, and they gradually fell to become undetectable. And at 1 year and 7 months, she later became pregnant and delivered a healthy infant. The case highlights the importance of recognizing discordant patterns. So discordant expression between villus mesenchyme and cytotrophoblasts is rare, but that's just not the case in complete mole, but also in partial mole and non-molar pregnancies. The authors do note that P57 can be expressed in a very small proportion, maybe less than 1% of cytotrophoblasts in classical complete mole, but this minor expression shouldn't be misconstrued as positive expression or even discordance. However, true discordance is occasionally observed, and even in their regular practice, they come across it, and not just in their referred review cases, therefore hinting that this discordance may be more common than we generally appreciate. The discordant patterns that are important to recognize include the case that we have here, which is demonstrated in figure A staining. And there are only a few in literature suggesting it's quite rare. Figure B staining pattern is actually a non-molar entity called placental mesenchymal dysplasia and is a bit more common. Figure C demonstrates that there may be heterogeneity between villi, and therefore multiple blocks of tissue may need to be stained to see what the predominant pattern is. It is generally thought that malignant progression is driven by the trophoblast, and if P57 is negative, then there is an increased risk of progression. However, and sometimes histologically, we can see that with marked atypia in the layer, as we can see with this case. However, by the same token, P57 positive cytotrophoblasts are thought to have a decreased risk of malignancy, but caution would need to be taken in this account because, as previously discussed, there might be heterogeneity of the villi themselves. Discordant patterns of P57 are rare, but it's important to consider the underlying biology. So it's generally a sensitive indicator, and if it's negative, it suggests angiogenesis of the cell lineage. But if there's discordance, then possible explanations include genetic chimerism, as they hypothesized in this case, which is the fusion of 2 zygotes resulting in 2 cell lineages that may not be completely androgenetic. And then another possible explanation could be the deletion of the maternal chromosome encoding P57, so CDKN1C. Future possibilities in analysis of these cases could include advanced methods such as laser capture microdissection or single cell sequencing, so we can get more detailed analysis of distinct cell lineages. Areas where there were detailed consideration of the case include staining of all tissue blocks and 3 separate analysis of areas of villus tissue rather than just 1. So that way they had more information to work with and they were able to draw more concise conclusions, even though the results are complex. Areas in which they could have gathered a little bit more concise information in hindsight was if they separated the villus mesenchyme for the trophoblast layer. Another area of improvement was that no particular explanation was given for the gestational sac, and incorporation of that into the results analysis. So we're not quite sure where that has come from. However, they do recognize and highlight the importance of documentation of more of these cases and the subsequent information pool that may help clinicians later with follow-up of these patients and understanding the genetic basis of the changes. If we were to apply the results and discussion of the case to everyday practice, it suggests that awareness of discordant results is important to recognize, and that also different patterns of trophoblastic hyperplasia could be in keeping with discordant P57. Documentation is definitely key, with publishing of case reports or case series to understand the natural history of the disease. And it also highlights the interesting changes that genotyping can explain some of these discordant results, and that further investigation for clinically suspicious cases can not only provide informative conclusions for the clinicians and patients, but also the pathologists themselves. Thanks, that's the end of my talk.
Fantastic, thank you, Angeline. You can stop sharing your screen, and Jayati, if you're good to go, that would be wonderful.
Yeah, hi.
Angeline, just before you go, that is such a conceptually challenging area, so well done on making that really easy to understand and walking us through those complicated graphics. That was really well done.
No worries.
Okay. Jayati, I'm going to turn off my camera and the floor is yours. Thank you.
Yeah, thank you. So good morning from Kolkata, India. Today, the paper I am discussing is about Dysgerminoma of the ovary, an analysis of 140 cases, emphasizing unusual microscopic findings and resultant diagnostic problems. It is a paper by Robert Young et al. In the August 2021 issue of American Journal of Surgical Pathology. As we all know, Dysgerminoma is a primitive ovarian germ cell tumor typically occurring in the relatively young. Studies analyzing microscopic variations of dysgerminoma in detail are very few, and unusual patterns have received limited comments in the literature. So this study was done to analyze the histopathology of this neoplasm and to systematically record the unusual features which may create diagnostic confusion. A similar recent study describing unusual features in seminoma triggered this work to explore if this occur in dysgerminoma as well, and availability of a large number of cases also allowed overall analysis of clinical and gross aspect so as to provide a survey of this important tumor. 140 pure dysgerminomas were evaluated with particular focus on microscopic features. The cases were largely retrieved from consultation file of Dr. Robert Scully, with some cases coming from Robert Young and some of them from Mass Gen Hospital. Cases in which dysgerminoma was a component of mixed germ cell tumor or arose out of a gonadoblastoma were excluded. The mean age was 24 years, which is younger than seminoma. The average age is, however, slightly less for mixed germ cell tumor with component of dysgerminoma. The signs and symptoms predominantly are mass effect arising from fast-growing neoplasm. However, hormonal manifestations like isosexual precocity can also occur due to syncytial trophoblastic giant cells and resultant stromal luteinization. Paraneoplastic manifestations include hypercalcemia, which raise a differential diagnosis with small cell carcinoma, and peripheral neuropathy. Importantly, the tumor was bilateral in only 4% of the cases, and the bilaterality may be asynchronous with gap as long as 15 years. Higher rates of bilaterality in the literature may be due to inclusion of gonadoblastoma-associated tumors, which are often bilateral. The growth size ranged from 1 to 30 centimeters. The external surface is usually smooth to bossylated. Large tumor may have surface adhesion. The cut surface is typically soft lobulated, creamy white to tan yellow. Necrosis, hemorrhage, and cystic change may occur, but only rarely they efface the typical gross feature. Hemorrhage is marked in tumors that has undergone torsion, and this gross appearance can be mimicked by lymphoma and small cell carcinoma of the hypercalcemic type. Dysgerminoma with a gritty section surface suggestive of calcification should raise suspicion for an underlying gonadoblastoma. On the left-hand side, we can see the typical gross feature of a cut surface of dysgerminoma. On the right-hand side, the tumor has undergone torsion, and so it is showing extensive areas of hemorrhage and focal areas of necrosis. So this is the classic microscopy of dysgerminoma. One can see nest and clusters of cells of variable size, size and shape, and the stroma shows moderately heavy lymphocytic infiltrate. The varied microscopic patterns one can encounter include alveolar, diffuse, macronodular, insular, cord-like, tubular, pseudopapillary, and follicle-like spaces. The stroma may show prominent fibrous band or stromal edema or luteinization. The infiltrate may be lymphocytic or granulomatous, and the granulomas may contain Langhans-type giant cell. Clusters of syncytial trophoblastic giant cell may be seen, and particularly problematic pattern for diagnosis are diffuse growth with inconspicuous septa, macronodules, cords, solid tubular formations, spaces mimicking glands or follicles, prominent fibrous or edematous stroma, and cells with amphophilic to eosinophilic cytoplasm. So we will deal with some pictures that describe the unusual morphology. This is the classic alveolar pattern. Note the septa with sprinkled lymphocytes. This is a diffuse pattern where there is only a hint of septa. This pattern is particularly problematic to differentiate from undifferentiated carcinoma. This is an example of insular pattern. The fibrous stroma here lacks the typical lymphocytic infiltrate. This is another example of insular pattern where the nest have central disformation of the cells and the stroma is edematous. Yet another example of insular pattern. Here the nest show retraction artifacts separated from the stroma. Here also the lymphocytic infiltrate is inconspicuous. Here there is nest of cell as well as small clusters of cell in the stroma, and the stroma is myxoid. This is an example of nodular architecture. In the left hand side, the nodules are confluent, and in the right hand side image, there's a single nodule which is focally intersected by delicate septa. This is an example of corded growth. Cords of variable size are seen, and this pattern superficially resembles sex cord tumor. Yet another example of corded pattern. Here the stroma is fibrous, morphologically resembling metastatic lobular carcinoma of breast. This is an example of corded pattern where the cords are very regularly arranged. In this example of corded pattern, the cords show a retraction artifact from the stroma. This is an example of trabecular pattern. In the left-hand side, we can see different trabeculae of tumors, and the septa lacks lymphocyte. In the right-hand side, the trabeculae have intervening stroma with lymphocyte. This is an example of solid tubular pattern. Here the tumor cells have a vacuolated cytoplasm resembling lipid-rich Sartoli cell tumor. This is an example of starry sky appearance. Clusters as well as single cells with vacuolated cytoplasm are present, and this pattern resembles lymphoma. This is an example of pseudoglandular pattern. However, if one sees carefully, the cells lining the spaces are identical to the cells between them. This is an example of pseudoglandular pattern. Here the pseudoglands somewhat resemble the tubules of a sex cord tumor. In this example of pseudoglandular pattern, there is again central disformation of tumor cells. This is an example of formation of follicle-like spaces, which may give rise a differential of juvenile granulosa cell tumor. In properly fixed specimen, the tumor cells are round to polygonal with well-defined cytoplasmic membrane and clear to amphophilic to pale eosinophilic cytoplasm. The nuclei have angulated membrane, granular chromatin, and one or more prominent nucleoli. However, suboptimal fixation can give rise to a number of artifacts, including poorly defined cell membrane, cytoplasmic autolysis, nuclear crowding, smudging, and retraction of cells. Previously, these changes were called anaplastic dysgerminoma. Another probable result of poor preservation is vacuolization and signet ring cell appearance. The stromal lymphocytic infiltrate may vary from striking number of lymphocyte to formation of lymphoid follicle to very scanty in some of the cases. Plasma cells may be a component of the inflammatory infiltrate. However, typically they are much less prominent, and numerous plasma cells should raise the possibility of a clear cell carcinoma of ovary. An additional characteristic feature is presence of granulomas with epithelioid histiocytes. The granulomas are usually ill-defined. Discrete, sharply outlined sarcoid-like granulomas are rare. Langhans giant cell may be found in 35% of the cases. However, they are rarely conspicuous. This is an example of formation of lymphoid follicle with germinal center in the stroma. This is example of granulomas. The granulomas are commonly ill-defined like left-hand side image. However, sometimes discrete sarcoid-like granulomas may also be present. Dysgerminoma may sometimes lack the fibrous septa and lymphocyte, resulting in a diffuse pattern of growth. The stroma may sometimes be very prominent, fibrous or edematous, and this fibrosis may range from standard fibrous tissue to hyalinized tissue to myxoid changes. In one of the cases, the stroma was cellular and pseudosarcomatous in character. So this is an example where the tumor shows unusually conspicuous fibrous stroma. In this example, the stroma is markedly hyalinized. Here, the stroma has prominent edema. Here again, the stroma is inconspicuous. The tumor cells grows in sheet with abundant eosinophilic cytoplasm. This pattern is difficult to distinguish morphologically from undifferentiated carcinomas. Here, the tumor cell grows as irregular aggregates of cells, and they have eosinophilic cytoplasm, somewhat resembling plasma cells, and one can see a syncytial trophoblastic giant cell just off center. In this example, the tumor cells have vacuolated cytoplasm, and a few cells resemble signet ring cells. Here, there are numerous scattered syncytial trophoblastic giant cell. Syncytial trophoblastic giant cell may vary from large, bizarre mononucleated cell to typical multinucleated cells. Immunohistochemistry isn't required in cases with classical morphology. However, they can aid in diagnosis when the morphology is difficult. The commonly performed stains include PLAB, CD117, OCT4. Negative stains include keratin, CD30, EMA, etc. Commonly, sulfur expression distinguishes dysgerminoma from sex-cord stromal tumor. However, one should bear in mind that sulfur expression has been documented in heterologous intestinal type glands of Sartori Leydig cell tumor and up to 29% of serous carcinoma. And when differentiating with carcinoma, EMA is more reliable than cytokeratin. Immunohistochemistry is particularly useful when differentiating dysgerminoma from other germ cell tumor. However, this pointer should be kept in mind that PLAB, commonly used as a marker of dysgerminoma, may stain embryonal carcinoma and yolk sac tumor. CD117 membranous expression may also stain solid variant of yolk sac tumor. OCT4 consistently stains embryonal carcinoma. Other useful stains include NanoG, D240 and SOX2, with dysgerminoma being positive for NanoG and D240 and embryonal carcinoma being positive for NanoG and SOX2. In routine life, we commonly use a panel of CD117, OCT4 and CD30. When small cell carcinoma of hypercalcemic type is a differential, a loss of SMARCA4 or BRG1 is very sensitive and specific. The common differential diagnosis one should keep in mind are clear cell carcinoma. They characteristically have a tubulocystic and papillary pattern, and they arise in a background of endometriosis or clear cell adenofibroma. Napsin A is very useful when diagnosing this tumor. Solid variant of yolk sac tumor have some areas where there is typically retained reticular and microcystic pattern. Glypican-3 and alpha-fetoprotein may help in diagnosis. Embryonal carcinoma is a particularly problematic differential diagnosis. However, usually one sees a striking rate of apoptosis in this tumor, imparting a dirty background. CD30 and SOX2 immunohistochemistry helps in differential. Undifferentiated carcinoma typically occurs in older age, shows extensive hemorrhage and necrosis. Minor differentiated epithelial component may be seen, and they are typically OCT4 and SALPO negative and EMA positive. Malignant lymphoma, if considered in differential, will be having less uniform cytomorphology. The lymphoid cells will have variable degree of maturation and cytologic atypia, and they immunohistochemically they will show positive lymphoid marker and EBER positivity in endemic cases. Sartori cell tumor, if considered in differential, usually shows a diffuse tubular architecture. Inhibin, calretinin, and SF1 helps in diagnosing this tumor. Melanoma usually has a prior history of cutaneous or mucosal melanoma. The cells may contain pigment, and S100 HMB45 may help in diagnosis. Small cell carcinoma of the hypercalcemic type usually show smaller tumor cells. If they are of the large cell variety, the cytoplasm typically have rhabdoid inclusion, and they are EMA positive and show characteristically loss of SMARCA4. So awareness of unusual morphologic variation and searching for areas of retained typical morphology is helpful in arriving at correct diagnosis when encountering a difficult cases. The varied problem encountered in differential diagnosis can be readily resolved with routine microscopic evaluation of well-sampled, well-fixed specimen, provided the pathologist is aware of the potential pitfalls. If necessary, IHC can aid in diagnosis. So the strength of this paper was a large number of sample, access to complete clinical details and gross findings. However, we should keep in mind that majority of this paper were consultation cases. Referral bias may be there, as cases with unusual morphologies tend to be sent across more often to solve the diagnostic difficulties. Thank you all.
Thank you, Jayati. A really comprehensive and beautifully illustrated paper, and you managed to sum that up really efficiently. Thank you. Also a somewhat scary paper in terms of all of the variant patterns and the way Dysgerminoma can mimic so many of the other entities that we see in the ovary. But I was trying to reassure myself that the point of this paper is that these are unusual and rare patterns and reflect a rich consultation practice. So hopefully the more classic pattern is the one that we will see most frequently. Well done, nice job. Okay, Luke, if you're ready to share your screen. Hello, welcome.
Yep, 1 sec.
Thank you.
Are we good to go?
Yep, good to go. We can see your screen. Thank you.
Excellent. Hi, everyone. I'm Luke. I'm one of the final year registrars from Melbourne, Australia. Thanks to Karen, Natalie, and the rest of the organisers for giving me this opportunity. So the paper today I'm discussing is bizarre Chorionic-type Trophoblast in second trimester and third trimester placentas by Murdock et al., published earlier this year. Just some introduction. The terms atypical, bizarre, and symplastic nuclei, these are being used to describe cells that have these large multilobated or multinucleated nuclei with smudgy chromatin and occasional pseudo-inclusions. These have rarely been seen in normal tissue. They can be seen in endometrial stroma and stroma of the lower tract, but they are also seen in a variety of neoplasms. The most common we'd be all aware of is the symplastic leiomyomas, but also they're seen in endometrial polyps and fibroepithelial polyps. And importantly, these carry a benign clinical course. So even at baseline, trophoblastic tissues show mild atypia, but then there are greater degrees of atypia seen in certain lesions, such as atypical placental site nodule and molar exaggerated placental sites. And these can raise the differential of a choriocarcinoma. There's a bit of a side point of this study, but there are a subset of uterine leiomyomas that show bizarre nuclei in context of fumarate hydratase or FH deficiency, albeit these tend to have eosinophilic nucleoli and perinuclear halos. So the objectives of this study were to describe the clinicopathologic characteristics of cases of second and third trimester placentas that contain these bizarre trophoblasts, in which the differential diagnosis of undersampled choriocarcinoma was raised, to add to the literature regarding bizarre trophoblasts within the female genital tract. And finally, it wasn't explicitly stated, but to investigate a relationship between bizarre trophoblast and a loss of fumarate hydratase. So these were historic cases screened by the authors by scanning the lab information system for potential cases that had the term atypia, bizarre, or symplastic. Clinicopathologic data was obtained from the path reports, the review of slides, the referring pathologists and clinicians, and from the electronic medical records. Any cases with metastatic carcinoma or gestational trophoblastic diseases were excluded. Initially, the investigators scanned the H&E slide for this atypia at low power with a 4x objective, and then further examined at a higher power at a 40x objective. And this atypia was categorized based on location, architecture, and severity, and then noted the presence or absence of intranuclear pseudo-inclusions. They went a step further and applied a dual immunohistochemical stain for hydroxyl delta 5 steroid or HSD3B1, which is a sensitive and specific pan-trophoblastic marker, and Ki67, which, as we're probably aware, is a proliferation marker. And they also stained a subset of cases for fumarate hydratase. So over the period, they found 17 cases in their records. The initial diagnostic impression for 7 of the 17 cases was trophoblast atypia favoring bizarre trophoblasts. 7 cases, it was initially bottom-lined as atypical intermediate trophoblast, but not further classified. In a single case, that was called bizarre trophoblast favor reactive changes. And lastly, a single case of the 17 bottom-lined as concerning for intraplacental choriocarcinoma. There was a wide range for the follow-up period, spanning between 1 and 45 months, with a mean of 8.5 months, and all patients following this were alive and well. And importantly, there were no macroscopic lesions on placental examination that corresponded to these lesions of bizarre trophoblasts. This is the first table from the paper that shows the maternal medical history. And you can see that, I'll come back to this later, but most of the cases of the 17 cases showed a prior medical history. And in the same table continued the current gestational obstetric history, with most patients showing a current obstetric history at the time of pregnancy. In the second table from the paper, it describes the histologic characteristics of these 17 cases. The most important notes here are that almost all cases showed a multifocal or patchy pattern. All cases but one had small lesions of up to 3 millimeters in greatest dimension. Intranuclear pseudoinclusions were almost a finding in almost every case. I'll touch on atypia and the proliferation index in a sec. And finally, most cases did show other histologic findings. So the initial blocks for the 17 cases, the mean number was 4, and then 4 cases went on to have extra sampling. And interesting, none of these extra sampling altered the final diagnosis. In all cases but one, these bizarre trophoblasts were seen at 4x objective. And then that one case that wasn't seen at 4x, it was visible at intermediate power at a 10x objective. And all these bizarre cells showed this epithelioid morphology with smudgy chromatin, inconspicuous nucleoli. They were usually admixed amongst normal appearing trophoblasts that were kind of multifocal or patchy. And finally, they were within this hyalinized fibrillary stroma. There was a varying nuclear cytoplasmic ratio, or NC ratio, in these bizarre trophoblasts, but most did not have a high NC ratio. And finally, and importantly, there was no relative increase in cellularity, there was no necrosis, and there was no invasion of other tissues. So in terms of grading the atypia, the investigators graded none of the bizarre trophoblasts with mild atypia. A minority, so 3 out of 17 cases, was graded as moderate. And finally, the majority, with 14 out of 17 cases, graded these as severe atypia. 15 of the cases were stained for that Ki67 HSD3B1 dual immunostain. 2 of the cases couldn't be stained due to the focus cutting out on extra levels, but in 2/3 of the cases, the Ki67 index was between 0 and 2%. And in the last 5 cases, it was between 3 to 8% compared to 0% in the background normal appearing trophoblasts. And in the 7 cases, that were stained with fumarate hydratase, there was intact expression within the bizarre trophoblasts as well as the background trophoblasts. And this is a normal pattern of staining. So this is the first image from the paper itself. And at low power, you can see these bizarre trophoblasts really do jump out at you. In this next image, the arrows are pointing to the almost common intranuclear pseudoinclusions. And on the right image, there is this very fibrillary to dense hyalinized stroma. And in this last image here, this on the right here, this is that dual immunostain. The red chromogen corresponds to the HSD3B1, so the trophoblastic marker. So you can see all the trophoblastic cells here. And the brown chromogen would correspond to the Ki67. However, there's no staining here, meaning that there is a 0% proliferation index. So cells with bizarre nuclei, we think that these are due, the ones in the gynecological tract and outside the tract are likely a neoplastic phenomenon. The reassuring features here are that they are intermixed with normal cells. There is that fibrillary hyalinized stroma. They don't form masses. They show no necrosis. They don't invade other tissues, and with a relatively low Ki67 index. However, the differential diagnosis, most importantly, is going to include choriocarcinoma, but is a bit wider, also including such as atypical placental site nodule and metastatic carcinoma. I thought it was interesting that in the 4 cases that blocked more tissue, the bottom line didn't change. However, it was recommended by the authors that if multifocal severe atypia is seen, or if there is an elevated Ki-67 index, that additional sampling would be recommended. This is a bit of a quick review of intraplacental choriocarcinoma, because it's the big diagnosis that no one ever wants to miss. It's a pretty rare diagnosis with an incidence of 1 to 10 cases per 40,000 pregnancies, depending on which study you look at. These are usually diagnosed in symptomatic patients with known metastases, but having an incidental diagnosis on placental examination is by far the least common presentation. Macroscopically, these usually appear as hemorrhagic and necrotic lesions, although there have been case reports about these having no macroscopic lesion. And histologically, they require a biphasic lesion comprised of malignant appearing syncytial trophoblasts and mononuclear trophoblasts, and they're often accompanied by hemorrhage, necrosis, and abundant mitoses. So this is a picture from the WHO 5th edition Blue Book. So this is an infiltrative lesion. And in the background, there is no fibrillary or hyalinized stroma. There's abundant necrosis here and mitoses. And the Ki-67 is high, typically greater than 90%, so at the end of the spectrum. And this is contrast to the benign, bizarre trophoblast described in the lesion. I've said this multiple times now, with the lack of a macroscopic lesion, the fibrillary stroma, the normal cells, the no necrosis, and lack of Ki-67 are really good morphologic features that distinguish this from choriocarcinoma and are reassuring for us. So these bizarre cells, these have been seen in uterine lymphomas for a long time now. They were described in at least 1920. And I find it interesting that even back then, over 100 years ago, these were favored to be benign on morphological grounds. This was later thought that these represented ischemic changes secondary to vascular insufficiency. These cells with bizarre nuclei have been described in multiple sites, gynecological and non-gynecological sites. In one study, they described these as these subepithelial stromal cells that were often intermixed with inflammation, and they had an identical immunophenotype with their neighboring cells, which included Vimentin and Desmond positivity. So it was at least postulated that these were reactive in nature, somehow having some primitive smooth muscle differentiation. But in regards to in these placental cases, the authors had a few ideas about a possible etiology. The first was there an association with ischemia? However, it was argued that placentas not uncommonly show single peripheral infarctions that are related to ischemia, and yet these bizarre cells are pretty rare. They wondered if there was an association with a loss of fumarate hydratase. However, in all the cases stained, they all showed normal intact staining. And to be fair, the morphology wasn't great either, as there was no eosinophilic conclusions. There are no other etiologies postulated by the authors, but I do wonder if there is an association with comorbidities. So going back to those tables, in terms of the clinical, gestational diabetes, hypertension, and preeclampsia do arise in a few of the cases. But more so on the histologic findings, there is a vague recurring theme of chorioamnionitis or subchorionitis, infarction, hematomas or thrombohematomas, or perivenous fibrin deposition. These are unlikely causative for these bizarre trophoblasts, but you can't help but wonder if there is some relationship with them. So to summarize this paper, the strengths of this paper, I thought it was a really good historical search. These cases span from 1984, albeit they did have some quite stringent search criteria with just using the terms atypia, bizarre, or symplastic. Their morphologic descriptors of these lesions was absolutely excellent, and their rationale about why they're benign. And they went a step further and applied some pretty interesting immunohistochemistry. The fact that follow-up data being available is always good. However, there are areas for improvement. So only 17 cases. These are few numbers. However, this is a rare phenomenon. You do wonder if this phenomenon is more prevalent. Either it's undersampled, it's not mentioned in a report because we know that they're probably benign, or if they're described in different terms, just especially not to worry clinicians or patients. I feel the grading of atypia is rather arbitrary, although the authors did admit this as such. And on this note, the descriptions of the architecture of the lesions is also quite subjective too. The potential low number of blocks could be an issue in terms of undersampling again. There was a mean number of 4 blocks per case, at least initially. and there was a mean, so there are some below and some above, whereas the Amsterdam consensus recommends a minimum of 4 blocks for placentas in all cases. And finally, it's a bit personal, but I would have liked a formal name for these bizarre trophoblasts. They've been described with a multitude of terms: bizarre, atypia, which can be worrying to some people, or symplastic. If we at least had a single term going forward, we could at least describe it a bit better and study it a bit better. But regardless, I thought that would have been nice. And finally, how this is applied to our practice, there is raised awareness about this phenomenon. I've never come across a lesion like this in my practice, but if it did, I would definitely be concerned for intraplacental choriocarcinoma. But now this study does provide a framework with how to deal with it. There are these reassuring morphologic features that are improved by immunohistochemistry that do reassure their benign nature. And they do provide criteria about when we should consider more sampling. That's it. Thank you.
Fantastic. Thank you, Luke. I was quite excited when I saw this paper because this is something that I have encountered a number of times over the last few years, but then I also report a lot of placentas, and I suspect it is a little bit more common. I think if you look hard, you can always see atypia in trophoblast, and bizarre atypia, I mean, it's very much open to interpretation, but I don't think it's that rare. So I was really pleased and reassured to see this paper because I'm terrified of missing an intraplacental choriocarcinoma. I've never seen one. Everyone tells me that if they're there, they'll be hemorrhagic and hard to miss, but I'm not so sure. So thank you, that was really good. If everyone who's got a camera would like to turn their cameras on, and you can unmute yourselves. Oh, we've got a question. In products of conception, I notice prominent hyperchromatic cells with bizarre shapes along the membranes. This seems to be a normal feature. Any comments? I guess I'll throw that to you, Luke, but I welcome anyone who would like to comment. And I have to agree with that comment. I think the chorionic-type intermediate trophoblast lining the membranes are particularly have the tendency to undergo or to present as bizarrely atypical cells.
I'm very junior, so my opinion is not the greatest, but as the paper mentioned, though, that trophoblastic tissues at baseline do show varying levels of atypia. So I always get the vibe that this is on a spectrum of normal and that atypia can be exaggerated in certain clinical scenarios.
Yeah, I agree. And I think it's the chorionic-type intermediate trophoblast in particular that has the propensity to undergo this bizarre atypical alteration. And maybe, as you were suggesting, there are certain clinical factors that weigh into that, such as ischemia or inflammation may exaggerate those changes. Does anyone else have experience with this?
Yes, Karen, so we see lots of placentas here at the Mater. And in fact, Deb and I were having a discussion prior to this about, we've reckoned we've seen that and just passed over it, not thinking Absolutely. It was probably not that significant. So as you say, it is really nice to have a name for it and something to back it up so that if you are worried about it. So I think that's particularly reassuring. And I agree also that out in the membranes, you'll often find single degenerate atypical looking trophoblast cells sitting there. And I imagine that's just a rougher neighborhood for a trophoblast cell to live in perhaps. So they just tend to be slightly more degenerate. So it's a reassuring paper. And I think the other interesting thing, I think Luke touched on it as well, is that no one seems to have mild trophoblastic atypia, which makes you think this is perhaps one end of a degenerate spectrum. Yeah, and it's just that once you get up that really atypical looking end, that's when people worry about it. And the rest of the time we glide over it.
Yeah, I was told very early on, don't look at high power on products of conception because we've got to glide over a lot of really atypical stuff. And, you know, intermediate trophoblasts permeate myometrial smooth muscle. They get into vessel walls, vessel lumina. They do scary stuff, and you've got to stay on low power, not or at least, you know, desensitized to that. And yeah, I think it's really got to be bizarre atypia to be noteworthy.
I think my question for Luke, sorry. Yeah.
No, go ahead.
My question for Luke would be, and when I was reading this paper, the Ki-67 is really nice, and that's, if you want your handheld and a bit of reassurance, you can see that being really useful here, and the double stain's really nice. I suppose my question would be, what do you do when you end up with your Ki-67 is a bit brisker than you anticipate, but it's not in choriocarcinoma territory? What do you do if you're in this middle ground where maybe it's a little bit razzed up, but not quite malignant? So, which sort of, it's their Ki-67 seem to fall very neatly down the bottom end of the scale. And I do wonder what you'd do if you found something a bit more intermediate.
It's a tough question that I'm sure everyone deals with. I like to say that morphology is king, and morphology should help us and reassure us and guide us. But then if we're doing the immunostain, the morphology probably isn't reassuring us to begin with. So I feel like you can't fall back on the morphology. Like all things pathology, I suppose you could cut levels and look at more tissue if it's available. But then if these are small biopsies, you're not going to have that. I guess from my point of view, I'd probably refer it out to a specialist or show it around, but I'm not sure how far we could go. You guys are the experts.
I think
Definitely showing things around. Yeah, I would say showing things to a colleague is my favorite answer to that question. I don't know about you.
You're just
all.
spreading the blame.
Yes. Well, also I mean, they have that co-stain, right? This paper comes from the place where I did my fellowship, and it's so nice. But I don't know if any of you have ever tried doing a KI in a place on a POC where you don't have a co-stain. It's a whole mess, you know. I mean, you can't. It's so inflamed, it's not really even worth doing. I mean, unless you have this like made up specimen of maybe like you're looking at an implantation site in, you know, a space that's not inflamed, which I don't think I've ever seen. So it's really special that they have this and they were able to write this paper for the rest of us, because we kind of have to fall back on morphology, just like you're saying, at the end of the day, I think.
Yeah, I would love to have a co-stain like this in practice, because every time I order the KI, I wish I hadn't ordered it, because it just creates a new problem.
And then you end up hand waving in your comment. Yeah, I know.
And invariably, it's usually in the setting of a placental site nodule that's a bit on the large side, has a little bit of necrosis, and you order it, and then you're compelled to call it an atypical placental site nodule because the mitotic index, at least in some high power fields, is over 5%. And and yeah, it's a slippery slope. So we probably do need to embrace that dual stain in our practice here.
Yeah, I think I don't even know that you can do it on a machine. I don't know. It's like pretty specialized, right? So I think you'd have to be in a pretty high volume place.
Yeah, no, that's true.
Yeah.
Our audience also posted a question on Ki-67, which I think we've amply answered. So I guess do it, but with caution, because you then have to interpret it.
Yeah.
Okay, we've got a couple of minutes left. Jayati and Angelina, I'd like to hear from you. Jayati, what was your main learning point from this paper?
So the morphological variations, you know, we encounter them day in and day out because Dysgerminoma is fairly common. We just don't pay heed to the variations because most commonly, you know, you have some basic IHCs to bail yourself out. So it was a very nice summary of those unusual morphological features that one might encounter. And this again re-emphasizes the fact that morphology is the, you know, the place where the play starts, and we should be really mindful of them. And it was reassuring to know that basic morphology can, you know, give documentation of basic morphology can produce a beautiful paper. As an, you know, as a practicing pathologist, I always feel that you need some molecular, these new generation IHCs to publish a paper in premier journals. But this paper was very reassuring on that point.
Yeah, I share that view completely. We've only got a handful of stains to use in germ cell tumours. CKIT, CD30, PLAP. OCT4, and that's it.
That's it. Yeah.
So yeah, we rely heavily on morphology as well. And it's lovely to see traditional morphologic papers like this get published, I agree. Angeline, thank you again for your presentation. What did you take away from this?
I think that it's quite interesting to sort of nut down on the genotyping and the molecular basis behind what you're seeing under the microscope, because we're probably just seeing the downstream effects of what's going on within the cell itself. And so looking at the paper and trying to understand the genotyping, the short tandem repeat analysis, I think that was the biggest take-home message for me, because it's just really interesting to see how everything works and then what you end up seeing under the microscope.
Yeah, I agree. I know that Rowan and Deb have genotyping in practice. I wish we did too. Unfortunately, we're not quite there yet. And I think most of Australia doesn't employ molecular genotyping routinely for problematic POCs. Do you have it, Natalie, where you work?
We don't do it in-house anymore, but obviously I did my training with Dr. Runnett, and so she does it on a lot of her cases, and the first author of this paper is, I think, a PhD scientist who does a lot of that work. And it's an area of debate. I think people feel differently about it depending on, what they believe about partial moles. So I think it's going to come down to what do we all think about those, right? Because we can usually suss out the complete moles, and then you're left with that differential. So I do it on some cases and not all cases, but I think it's always a challenge. I don't know. So you all don't do it at all where you are practicing? No.
We do ploidy.
Mm-hmm.
So we'll be overcalling partial moles because we're using ploidy as our gold standard.
We used to have it in-house, but it wasn't sustainable because all the GTD follow-up got centralized in our state. So the service got transferred to another institution. And I do believe they do a reasonable amount of it routinely, but we used to use it for our query partial moles. We'd confirm triploidy first with fish and then go on and genotype it. And it was great fun. Technically difficult, they're never the best specimens. There's a lot of micro dissection and fiddling about, but it's a really useful technique.
Yeah, I think it's the reason that it's sort of limited, and it seems like that's a common story of places do it and then it's not sustainable, is that it's very labor intensive to do that micro dissection. And so if you're not doing high volumes, it makes sense to centralize that testing. But I think, from a patient perspective, especially patients maybe with infertility or things like that, they don't want to wait to know if they have a partial mole. They would rather just pay the money to find out. Yeah. So those are always
that was the driver for us. Yeah.
Right. And so usually what I do is some mix of, weighing my suspicion with conversations with the clinician and the patient, and what's their threshold of uncertainty and things like that. So yeah, but it's a hard decision because we all, as physicians, we want to know answers, but we have to weigh that with all the other concerns.
Well, we've gone over time, so we probably should wrap it up. I first of all want to thank Rowan and Deb for joining today. I'm so excited to have you guys on board as co-moderators. Looking forward to working together. And our three presenters, you did a fantastic job. Thank you. Without you guys, we wouldn't have this to present to the audience. And finally, congratulations to Luke and Angeline for successfully passing your exams. It's exam season here. I know results have just come in. I know you've still got a Viva to go, Luke, but I'm sure you'll breeze through that.
One day at a time.
Good luck. All right, everyone. Thank you. We'll see you all next time. Thank you, Natalie.
Yeah.